All right, so this is chapter 34, traumatic and acquired brain injury, management and treatment. Before we learn how to manage and how to treat anything, we have to know what it is and what some of the problems are going to be that are associated with any type of injury or illness that we work with. So we're going to go over sort of what some common causes of traumatic or acquired brain injury are. And also we're going to talk about the difference between traumatic and acquired brain injury, and why it's so controversial. So in this chapter, we're going to talk about brain injury types, address some management, some treatment. We're going to talk about the Ranchos Los Amigos scale of cognitive functioning, which is the universal scale that everybody who works with traumatic brain injured patients use. And some of the information that you're going to have in here have already been introduced in other chapters, especially in 204. So if you don't remember a whole lot about 204 and some of the information that you've gotten from there, then I suggest you go back and sort of look at some of your notes, some of your PowerPoints, reread chapters if you need to. So after going over this chapter, you should be able to distinguish between what a traumatic brain injury or a TBI is and an acquired brain injury or an ABI. You should be able to describe the levels of Ranchos, or the levels of the Ranchos level of cognitive functioning scale. You should be able to describe OT interventions for the symptoms that are associated in the within the different symptoms or different stages of the brain injury, and explain the role of the OT practitioner, especially when it comes to education of family members and other members of the treatment team. Some of you may remember Gabby Giffords. She can't remember if she was a congressman or a senator, but she was campaigning outside of a supermarket one day and got shot in the head. And that injury, that issue brought a lot of traumatic brain injury to the forefront. And despite what someone said 6 years ago or 4 years, however long it was, traumatic brain injury is much, much more than a really bad headache. It's way more complicated than that. Also, I'm sure a lot of you know who Tracy Morgan is. He has a brain injury. And if you look at some of his work before he got the brain injury and then look at it now, there's an obvious difference in his performance since he acquired the brain injury. Bob Woodruff, he was a newscaster. I think he was in Afghanistan over there doing something. And there was a bomb that went off and he acquired a brain injury. And then Olympic skier Dave Irwin, he also had a brain injury. And then you can look at these films, the Regarding Henry, Descendants, and 50 First Dates. Those are fictional, and that is not typical of what you see in brain injuries. So I wouldn't, you can watch these movies. They're good movies, especially 50 First Dates. I thought that was a great movie. But it's not typical, so don't hold a lot of, don't gear treatment or what you've learned on those movies. All right, so we're going to talk about the difference between an ABI and a TBI. There's a lot of controversy that goes with these. An ABI is acquired, such as one girl had an acquired brain injury from a nut allergy. Some people may experience oxygen deprivation. Carbon dioxide poisoning can also be considered an acquired brain injury. And then you have a traumatic brain injury, which is your TBI. TBIs are considered to be traumatic because they're normally caused by some type of force, external force. Stab wounds, gunshot wounds. The football is a lot, one that sport that I can think of that a lot of players have traumatic brain injuries. Um, Car accidents, ATV accidents, things like that. Um, but if you think about it, all brain injuries, whether they're traumatic or not, are still acquired. I always call it a TBI, a traumatic brain injury, because to me, I think a brain injury is traumatic no matter how you get it. Um, but just know that that's the main difference. When you hear someone call it an ABI, they mean some sort of cause that was not really a traumatic accident. Okay, so generally, a TBI is defined as an insult to the brain from an external source. Um, a CBA, brain illness, infection, anything else that's acquired after birth can be considered an ABI or a TBI, either one. Yes, CBAs are considered traumatic brain injuries. Also, TBI can be referred to as a concussion. Um, when people are playing contact sports such as football, even wrestling, they will experience concussions. And what a concussion is a mild traumatic brain injury. If a person experiences so many concussions, then their brain injury just continues to get worse to where you see definite changes in personality and judgment, things like that. My son, for instance, my older son, he played football for years and years and years, and he was always the one getting hit. I don't know what his position was. He was the one that spiked the ball or gave the ball to the quarterback. I don't know. Um, so, he was getting hit constantly and had a lot of concussions. Um, and a lot of you all know that he has a drug issue. He has drug problems. So not only did he have several concussions, but he also has brain injury from the drugs. And but before he started with the drugs, he got the drugs from a football injury. He had to have a knee surgery, and the doctor just prescribed him oxycontins like they were candy, and that's how he got hooked. Um, but I could see definite differences in his judgment, in his safety awareness, um, even before that. So concussions are serious, and they will say that there's concussion proof helmets, and there's not. That's a lie. There is no concussion proof helmet. Um, so a mild TBI again is referred to as a concussion. But then you have moderate TBIs, and those are characterized by a loss of consciousness of about 30 minutes to 24 days, or 24 hours, I'm sorry. Um, Sometimes the mild or the moderate concussions can include a skull fracture, but not always. They don't always have to be. Um, and then a severe TBI, that is a loss of consciousness for more than 24 hours and a memory loss after the injury for more than 24 hours. Um, and even a mild TBI, uh, brain injury can be profound if there's mild effects. then the brain injury can be profound. Severe injuries can leave a person permanently unresponsive or in a vegetative state. That's what vegetative state means. They have a full absence of awareness and responsiveness. Okay, so a DAI, a diffuse axonal injury, that occurs in about half of all severe head traumas. Um, and that makes it one of the most common traumatic brain injuries, is from a DAI. Um, Instead of it occurring like in certain focal areas, it's more widespread. And it's really one of the leading causes of death in people with TBI. So if you think about it, let's say you're in a car accident and someone hits you from behind. Your head, your brain is not attached, so it's just up there floating around in this fluid. Um, and the blood-brain barrier, it is there to protect from bacteria getting into the brain, but there's nothing to protect it from bouncing back and forth. So when a person hits you from behind, what's the first thing that happens to your head? Right? You go forward. So your brain bounces forward and it hits the front of the skull. So then you'll have a bruise or something on the front of the skull. So your brain just kind of bounces around in there, like, when you throw a ball at something, the ball will just kind of bounce around. It's the same with the brain. The brain will bounce around so it doesn't hit back. It doesn't go from forward to back. It can go from forward to back, but it also goes forward to the side, to the other side, diagonal, and to the back. So that's what a diffuse axonal injury means. It's just overall brain injury. And also that can also be a skull fracture, but doesn't have to be. Um, and that's why you have such widespread issues when it comes to traumatic brain injuries. It's sort of like a snowflake. There's no one that's the same. So when you're working with a brain injured patient, you have to keep in mind that, if you had someone with a level 6, in a level 6 Rancho Los Amigos, then, and someone else over here in a level 6, they're not going to require the same type of treatment. They're different. Everyone is different. Every TBI is different. Then you've got anoxic brain injury. Does anybody know what anoxia means? And you can unmute yourself and just call out. You don't have to. Okay, so anoxia means without oxygen. Okay, remember the A in front of anything means without. Anoxia means without oxygen. So it can also be called cerebral hypoxia, or hypoxic and anoxic injury. I just call it anoxic brain injury because that's what it is. And it's very serious, and it's a life-threatening injury or insult to the brain. After about 4 minutes of significantly low oxygen, brain cells will begin to die. And after about 5 minutes, you've got a permanent anoxic brain injury. So normally, when the person has an anoxic brain injury, and I have seen these, you see these more often nowadays than you used to, but certain drugs can cause anoxic brain injuries. Heroin is one that it sort of treats your body like morphine. It's just morphine on steroids in a way, and it will deprive it. It just kind of lowers uh, your pulse rate and just all of your vital signs. And when you overdose on heroin, it deprives your brain of oxygen. So every time that they are brought back using Narcan, they may have some type of anoxic brain injury. Um, okay, so next we're going to talk about the Glasgow Coma Scale. The Glasgow Coma Scale only measures comas, okay? And it measures 3 separate parameters, okay? There's eye opening, verbal response, and motor response. If you look at page 889, table 34.1, if the person, they start doing this Glasgow Coma Scale within the first 24 hours. But if the person is in a vegetative state, it's considered a wakeful unconsciousness. They may be awake, but they have absolutely no purposeful movements, no purposeful responses. And that is given to a person when their coma lasts for at least 1 month. Recovery from a persistent vegetative state is normally, it's just unpredictable. With that, you really can't determine if the patient will achieve any type of a functional life again. But anyway, with the Glasgow Coma Scale, you rate them anywhere between 3 to 15, or that's what they'll get. Like the 3 to 15 is their overall score. The lower the score, the more chance that they have to not recover. So if they are opening their eyes to pain, then you score them a 2. If they make sounds, but the words are not understandable, you score them a 2. If they have an abnormal flexion to pain, and what that means is if they're in pain, like say they stub their toe or something, and 10 minutes later they flex up, that's an abnormal response to pain or abnormal flexion to pain. So you would give them a 3. Okay, so if you score all that, that's their overall score. The lower the score, the worse their recovery will be. And really, there is no way to wake them up. If they are in a persistent vegetative state, they just are there. And we'll discuss when we get to it, to the Ranchos levels, what you do in that case, because there are ways to work with them when they are in a persistent vegetative state. But just know that the Glasgow Coma Scale only measures comas. A lot of times students will confuse that and want to try to use it with the Ranchos Los Amigos. It doesn't work that way. It's only the coma scale. That's a scale into itself. Okay. I think I have a copy of that, and if I do, I will print it out and give it to you. It'll make a little more sense if you're seeing it in person. It starts out being used in hospitals, in acute care, as soon as the person comes in and they are, in a coma. The people who use it would be the doctors, the nurses, the PT, the OT, anybody on the team who is going to have anything to do with the person who is in the coma, we'll use this Glasgow Coma Scale. So the main use of the Ranchos level of cognitive functioning, you also see it as LCFS. This is to determine what level traumatic brain injury this person has. Your ultimate goal of the LCFS is to get this person to the next level up. The lower the level, the worse they're functioning. The higher the level, the better off they are. And so this LCFS is used throughout treatment. It's not conducive to only a coma. Okay, it doesn't really measure comas. It's for functioning. Okay, so if you look at page 889, table 34.2, level 1 would be no response. Level 1, 2, and 3 are the lower levels, and that's when the patient is still sort of in a vegetative state to a point. They're no longer in the level 1, they're probably still in a coma. So that's when you would see the Glasgow Coma Scale being used. But it goes all the way up to 8 levels. So, there's 10 levels, but we're only going to talk about 8 because usually by the time they get to that level, they no longer need services. All right, so let's go back just a minute and we're going to talk about the two different types of traumatic brain injury. You've got the open head injury and a closed head injury. An open head injury is when something penetrates the skull, such as a bullet or a stick, a knife, something like that. And it's usually confined to a small area of the brain. So the open head injury is something that you can see, something tangible that the doctor can work with. The closed head injury, however, is a lot more dangerous than the open head injury. Where the skull has the sutures, there is no room for anything to swell. And so in a closed head injury, you really don't know if the swelling is happening. You don't know if there's a lot of bruises. You don't know where the injury is most significant. So that's when you see the doctors go in and remove part of the skull. And that allows for some of the swelling. Because if it keeps swelling and there's nowhere for it to go, the brain will just implode. And it will be death. All right, so just keep in mind that the closed head injury is much more dangerous than the open head injury, okay? All right, so if you look over at page 890, if you look at the symptoms and treatment by level, some of the symptoms that you're going to see in everyone who has a traumatic brain injury, no matter what their level, are dysphagia, which is difficulty swallowing, hemiparesis or hemiplegia, which is one-sided weakness, visual impairment, vestibular difficulties, balance, dizziness, sensory impairments, ataxia, cognitive deficits, apraxia. So do you see how a lot of what we do with someone with a brain injury is very, very similar to what we do with someone who has a CBA? It's just it takes the CBA, I don't want to say it's not, I mean, it's bad, yes, but it's not, you don't really see as severe problems with the CVA as what you do with a TBI. But a lot of the treatments are exactly the same. So with Ranchos Los Amigos, Ranchos level 1, no response. At Ranchos level 1, the patient is not responding. That they don't respond to any type of external stimulation. Normally, they're in an acute care hospital, possibly still in the ICU. For our focus, what do you think our focus is in this type with level 1, with the Ranchos level 1? What would you think would be our focus for OT?
Comfort.
Comfort? Explain. What type of comfort? What do you mean by comfort?
Like if they're in bed, making sure they don't get sores and things like that.
Yes. So positioning. When you say comfort, I think of comfort measures in hospice.
I couldn't think of the word positioning for a second.
Yeah, okay. So yeah, but you're right. Positioning is very important, because if you don't position them correctly, they're going to get bed sores. They're going to develop contractures, things like that. So what else other than positioning do you think is important?
Hygiene.
Hygiene is important, yes. Now that hygiene will be done by an outside person, because the patient is not going to be able to participate in any of their hygiene at all.
So
What
like
else?
caregiver education.
Caregiver education is extremely important, yes, especially at this level. What else?
Passive range of motion, so their joints don't get
Passive, yes, absolutely. Passive range of motion. Also, orthotics management will be important at this level. The patient may need some type of a contracture splint, some type of a resting hand splint, to keep them from contracting their hands when they sleep, because that is, remember, we're talking about the patient is going from a fully functioning person to back to an infant. Okay. And when an infant is born, how are their hands typically formed? What do their hands usually look like?
They're closed.
Right. They're completely flexed. So this is the person that is, in the stage 1 and level 1, their hands are going to flex up. Their body's going to flex up. So if they're not getting proper positioning, proper contracture management, proper orthotic management, proper passive range of motion, if they do get to the point to where they can become functional again, if they've developed bony contractures, how functional do you think they're going to be? So that's why it's important to do this from the very beginning. Okay. Also, sensory stimulation is important. So the main goals for this client, what do you think would be some of the main goals for the person who is in a level 1? Now remember, you're trying to get them to a level 2. Okay. If you look at the level 2 and consider what that is, then you'll know how to move your patient forward. Okay. So sensory stimulation is going to be important. What would sensory stimulation involve when it comes to the person in a Ranchos level 1?
Are you talking like E-stim and stuff like that?
Think a little lower, a little more everyday items that families can participate in.
Vibrations.
Vibration. Yeah, what else? Think about all the senses first, not just touch.
Light.
Light. You can maybe do some different colored lights. What about hearing?
Music.
What?
Music.
Yeah, music. Playing music. There's a certain type of music that everybody likes music of some type. There's certain, some like rap, some like rock, some like, classical. Play music that is soothing to them that they can possibly hear, because nobody really knows if a person who is in a persistent vegetative state or isn't in a Rancho level 1 with no response, nobody really knows that they can hear. Um, I think that they can. That's why you want to make sure that the family members or the caregivers who are in the room with them don't talk about them like they're not there. You want to educate the family and the people on the team to speak to the client, even though they're not responding. Speak to them like they are. Okay, what about smell or taste? What about those senses?
Smell, maybe have like a certain scent sprayed around the room, because I doubt you'll be able to have candles or anything like that.
That some places will let you have candles if you use one of those tart warmers or electric warmers and not an open flame because of the oxygen that's being used. But some will let you use that. Yes, different scents. Now, don't give the person something to eat unless the speech therapist or the nurse or the doctor says that they can have something. But smell and taste are so closely connected that if you play or if you have say the person's favorite food is chocolate, and you spray some type of a brownie scent, because they've got all kinds of scents, or even like banana nut bread or something like that. Not only will they be able to smell that, but they may be able to taste it as well because it's so closely connected. So those are a lot of what you're going to treat. So how are you going to involve the family? Because 9 times out of 10, a family member will be with this patient.
Educate them on ways to give them the stimulations.
Right. Yeah, you're going to involve them with, okay, well, what was you're going to ask questions about what they liked prior to the injury, prior to the accident or the brain injury. And, say, well, okay, can you bring in some of their favorite music? Or can you bring some of their favorite scents? And, always involve the family members, because they're going to be there normally day and night helping and trying to get their person up and going again. A lot of times they will interfere, but normally they try their best to do what you tell them to do.
Maddie, the music man, he was called the music man, and he would come to every room. Hold on, baby. When my brother was in an induced coma, he had us sing some of his favorite songs, and he would play the music. So like he really liked Secret Agent Man growing up. So my grandma singing Secret Agent Man, singing and stuff.
Oh, really?
Yeah, they definitely incorporated all of us. So it was really neat to see how.
Yeah, so all of that stuff, the stuff that they liked before, have the patient's family bring it in. Um, they may have a favorite blanket that they used. Bring that. They may have a favorite pillow that they used. Anything that is familiar to them will help. Okay. So we're going to talk next about Ranchos Level 2. Ranchos Level 2, that's a generalized response. They will react to a certain type of stimuli, but it's very inconsistent and non-specific, non-purposeful way. And they are considered to be in a vegetative state at this point. Level 1 and level 2, they're still considered to be in a vegetative state. Usually with this level brain injury, they are in an acute care hospital, or they may have been moved to an inpatient rehab facility. It just really depends on the availability at the time and the client's insurance and things like that. That all plays a factor into where they go. So what are some of the focuses? Now, keep in mind that, they've just moved from a level 1 to a level 2. And they're still in a persistent vegetative state. Their movements are not functional. And they react, but very inconsistently and non-specific. So what types of treatments do you think you're going to see or you're going to do with this client, with a client with a level 2 LCFS?
I feel like it would be a lot of the same.
Yes, absolutely. A lot of the same. Now, if you look over at Ranchos Level 3, okay, your ultimate goal is to get them from a level 2 to a level 3. So they have localized responses in a level 3. So, and what do I mean by localized responses?
Does that mean like if you put vibration on their leg, they might move their leg a little bit?
Yeah, it's localized means they respond in an inconsistent manner, but to specific stimuli in a local part of their body. So it's no longer a generalized response. So exactly, that's exactly what I mean. So for generalized response, you're going to do a lot of what you did with level 1, but you're really going to try to get them up, get them out of the bed. A Hoyer lift is probably going to have to be used because remember, they have absolutely zero function. Okay. So more orthosis, collared thermoplastics, brightly collared things are good to use. Because even if they're not responding to it, when they look, they may see these different colors and respond to that. And it can also help to make them aware of their affected extremity. If you're putting on brightly colored and not just a regular white orthotic. And also when sheets and stuff like that, bright collars are usually caught faster. Now, the sensory stimulation that you're going to provide is going to focus on providing specific sensory input and observing their response. Okay. In the level 1, just any type of sensation is fine. Any type of sensory input is good. Level 2, specific. Be specific and note their responses to this specific stimulation. Okay. So one thing that I have done is rubbed, because some people do not, they hate the feel of cotton. So I would take cotton balls and rub like their arm or their face or their leg or something like that with it. And if they responded, it was inconsistent. It was an inconsistent manner, but it was, and that's why you've got to be very, very patient and really observant. But if they would respond to this specific type of stimuli of the cotton ball, I kept doing it. And I know it sounds sort of torturous, but it's really not. It's a way to elicit a response. And it's a way to kind of wake their system up, wake their senses up and say, join the rest of the world. Okay? Because if they're not provided with some sort of stimuli to wake them up, they're going to be stuck in that level forever. And you don't want that. You want to get them back to where they can actually function in society. Okay. Is there any questions on level 1 or level 2? Okay, so next is your level 3. What do you think would be a typical presentation of a client at a level 3? And they have a localized response to stimuli.
Their eyes are more open and they're able to fixate on like one object or one person.
Yes, their eyes are more open. And yeah, exactly. Now, again, they may be in an acute care hospital. They also could be in a inpatient rehab facility. A lot of factors play into that. And a lot of times at this level, they will have an increased tone, muscle tone. Either be hypotonic or hypertonic. Most of the time, it is a hypertonicity or a spasticity that you're seeing. So what do you think you should do if the person is developing hypertonicity or spasticity? What's the best way to normalize muscle tone?
Range of motion.
Nope.
Weight bearing.
Weight bearing.
Oh,
Absolutely. So you're going to want to do some weight bearing exercises, activities with these clients to help to normalize their muscle tone. And this is also going to give input to the brain and kind of wake the brain up and say, hey, you know, we're doing this, we're coming out of this, we're going to get functional again. So you want to also provide positioning. You're still going to continue to provide specific sensory stim. Also, the different positions that they get into can elicit a specific response depending on what you want them to be able to do. So if you put a person in side lying and their hip is slightly flexed, they may be able to decrease some of their lower body extensor tone. And that can help prevent foot drop. Because a lot of times they're going to present sort of in the typical manner like a CBA, lower body extensor and upper body flexion. So with range of motion exercises, it's really important to do those passive or active assist as much as possible. The patient's going to have a really difficult time with any type of attention and any type of processing to their sensations or the input of the sensory stim that you're giving them. And they don't understand, like if you're giving sensory stim at the same time you're doing range of motion, they get confused and have absolutely no idea what to pay attention to. So try to, in the beginning, limit how much sensory stim you're giving them while you're doing something else. And then towards the end of their sessions, then you can, play soft music while you've got some scent, some candle in the background while you're doing passive range of motion, while, holding cotton balls or something. You can provide a bunch of sensory stimulation and, towards the end of your treatments with these patients. You will overwhelm their senses, yes. And they may get angry and shut down, but you're getting that sensory input in where it needs to be. Now, at this point, how do you think you're going to work with PT? Because PT and OT normally work extremely close together when it comes to with CBAs and TBIs and all that. How would PT fit into the treatment of someone with a Ranchos level 3?
Like balance and stuff?
Balance, part of it, but you're really not as concerned with balance right now as you are with getting them out of their vegetative state, providing sensory stim.
I would think that PT would be working mostly on the range of motion part, as the OT would do the other senses, like you said, with smell and trying, like the cotton ball. Like you're both working at the same time, but they're going to be more the mechanics of things. The PT.
Yes, to a certain point. The PT, they're going to use a modified Ashworth scale, which assesses like the different types of tone or hypertonicity in different muscles. They will be working on range of motion. They're also going to be working with positioning on getting them setting up, because you want to get them in a normal upright position at this point. So, and they're going to work with you on wheelchair management, different adaptive equipment that they may need, or durable medical equipment they may need to go inside their wheelchair, like positioning devices. If you look on page 893, that's what a typical person with a level 3 Ranchos Los Amigos would look like. They have no head and neck control, so they're going to need some type of a pillow or some kind of a reclining wheelchair that holds their head up. The PT will work with you on that. they're going to vestibular. Now, if they're going from lying to sitting, then you're going to have to do that in stages. You can't just automatically go from lying down to sitting, like lying down at 180 degree and then moving to an angle of sitting straight up without experiencing some sort of dizziness. So you're gonna angle their bed to the point to where they are eventually sitting straight up. You're gonna do that slowly from the level 1 up. And physical therapy is going to help with that. When it comes to getting them sitting straight up, then physical therapy is going to help with that as well. Now, how do you think you're going to involve the family in this type of, remember, because we're family oriented, we're client centered, but we're family oriented. The family is going to be extremely important in the overall outcome of someone with a TBI. So again, what type of education are you going to provide to the family for the Ranchos Level 3?
I think a good way to start is explain to the family what you're doing with the client and why it's beneficial, and maybe how they can jump in and do certain things too when you're like there.
Yes. Yeah, exactly. You're gonna tell them, this is where we're at now, and then you want to also provide them some education of what they might see next. And we're getting ready to go into the Ranchos Level 4, and this is fun. Not really. Also, let's go back to sensory stem, to the vestibular portion. Orthostatic hypotension is a drop in the blood pressure, like a sudden drop in blood pressure when the patient goes from supine to sitting. And that's another reason why you want to do this slowly, to decrease the chances of them having orthostatic hypotension. Who remembers what you do when the patient experiences a sudden drop in blood pressure? What is the response that you should have when they experience dizziness because their blood pressure decreases?
Stop the treatment session.
No. First off, is it a medical emergency?
If it's just a slight drop, then no.
So what would you do if you ever experienced, when you get up out of bed in the mornings and you sit up too quickly and you get dizzy? Has anybody ever experienced that sensation?
Yeah.
Okay, so what do you do?
Sit back down and take a break.
So that's the exact same thing you're going to have the patient do. When I sit up too quickly and I get dizzy, I lay back down for a minute. And then I get up slower. And that's the exact same thing you're going to do for your patient. So orthostatic hypotension, the way to, if your client has this, just lay them back down if they start getting dizzy. And that's why it's important to have a reclining wheelchair. And that's also why it's important to start them slowly, that slow incline into sitting straight up. Okay, so any questions? Let me get out of here. Any questions on the first 3 levels? Any comments for the first 3 levels? All right, so we're going to go into the level 4. All right. Level 4. This is when they are beginning to wake up. They're waking up and they're coming out of that vegetative state and they are totally pissed off and confused. They have absolutely zero clue where they are, what happened to them, why they're here, who you are. They don't know you. You could have worked with them every single day through the first 3 levels, and then they still have no clue who you are. Now, if you are put in that position, you yourself, put yourself in that position. You wake up suddenly one day and you're in some room that's got a bunch of different machines and a bunch of noise, and you've got weird people all around you, and you've got all these lines and tubes and stuff like that hooked up to you. What's your first instinct?
Get out of the room.
What?
I guess like try to get out of that situation. So
Right,
like,
exactly. You're going to start pulling those things out of your body. You have no idea what these tubes are and why they're there, so you're going to pull them out. You're going to try your best to get out. You're going to do anything that you can possibly do to get out of that situation. That's exactly where your patient with the Ranchos level 4 is. That the level 4 is confused and agitated. And they can be violent. It really just depends on the person. But they can be violent, and they're going to be bizarre, inappropriate, very poor attention, very short memory. They're going to be impulsive. They're going to have balance deficits, poor safety awareness. They're going to be very agitated. Sometimes they'll be in an inpatient rehab facility, but sometimes they are transferred to a higher level of care. Okay. So what do you think we do? What are the goals for this client?
I feel like education would be number one. Trying to get them oriented with what's going on and what happened and what continue to happen.
And that wouldn't be number one. Think about what is our main goal. What do we always want to consider with clients?
Safety.
Safety, right? Because this person is ripping out IV lines and catheters and trying to escape and trying to get up out of the bed when they can't walk. Safety is our main concern when it comes to someone in a level with a level 4. So restraints may be needed. And this is one of those, I don't like the use of restraints for most patients, but restraints when it comes to a level of safety are necessary. And restraints for the level 4 TBI patient is necessary. Sometimes they put them as, it's sort of like a tent. It's a tent that goes over their hospital bed. It kind of wraps around the hospital bed and it zips from the outside so that they can't get out of it. That type of restraint may be necessary and is normally necessary. They may have to have their arms tied down if they keep pulling out their IV lines and their catheters and things like that. So, also trying to get them aware, some safety awareness, some mitts that restrict movement may be necessary. You're going to want to talk to them or to try to work with them on attention. They have the attention span of a gnat, so they can't pay attention to anything. They're just here and there and blah, 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 and then and think about the lowest primitive level of human that you can think of. They are responding to only their basic needs. If you think about Maslow's hierarchy of needs, basic needs are what their responses to. They may play with their poop, throw it at you. If you put something in their hand like a toothbrush, they're not going to have any clue what to do with it. So you're going to try to work with them as closely as you possibly can on what a toothbrush is and where it goes. And consistency is going to be very important at this junction. A lot of times, especially in the level 4, they have one particular person that they respond best to. Most of the time it's their mom. I have been around patients that have a level 4 TBI, and if they know nobody else, they know their mom. So, if possible, it's important to try to get their mom there. If the mom is still around, or if, that sometimes there's some family dysfunction going on, and mom can't be there. So you try to get the next closest person if possible. Sometimes the person will latch onto you, and you'll be the only person who could do anything with them. God help you if that's the case, because then anytime that there's a problem, the nurses are going to call you and say, we can't do anything, and you'll have to come and do something with them. Let's see. So the plan of care at this stage is normally focused more on attention, safety awareness, behavior management, and ADLs. They say IADLs, but you're really not going to get a whole lot of IADLs if you can't get any ADLs. But, that's what they say. Some familiar things that they did prior to their accident, as long as it's safe. You don't want to have them around an oven or an iron. Anything that can be used as a weapon, anything that they can really hurt themselves on. Making maybe a sandwich, as long as it doesn't involve using a knife. Making instant pudding, because a lot of times they will be on some type of restricted diet for problems with swallowing, and they may still have a feeding tube. So making like instant pudding, things like that they can actually eat after they make it, is a good thing to do. You want to do it in a very low stimuli environment. So normally taking them to a room that has very little going on, no windows, very little noise, no other people, just very low stimuli is the best, because if you introduce a lot of stimuli to them, or if they go into a room with a lot of stimuli, they're just going to be looking everywhere. So low stimuli. Calming voice when you're trying to redirect them, and you will redirect them constantly. It's almost like, you're saying, okay, look at me, look at me, look at me, look at me, grab the spoon, look at me, grab the spoon, look at me. And that's what you get done. You're constantly redirecting in a very calm voice. If you get angry, they're going to get angry. So you want to do that. And family education also during this. Now, if family is present, you can bring a family member with you to the treatment session, and introduce them as another part of stimuli. If you're trying to increase their attention to their attention span, you can bring in one other person, and normally it's family is best. You're going to want to reorient them, and kind of Do you know what today is? Do you know what the weather is outside? If it's June, what type of what's the weather like? Um, and that's going to be a clinical judgment on your part when you redirect, when you orient them, when you confront them, when you ignore them, um, and when you confront them about their behaviors or reactions. Sometimes it's best to ignore it, but if you ignore it at the wrong time, then somebody could get hurt. So clinical judgment is going to be a big factor on treating the level 4 TBI patient. You want to talk about hobbies and things like that that the patient had with the family members, and maybe try to incorporate that into some treatment. Standing balance can be worked on while doing ADL treatments, like standing at the sink, and PT is going to play a role in that as well. Sitting balance when you're working on typical dressing, things like that. Also, if they have like a specific type of shampoo or stuff like that that they use, having the family bring that in so that they can use stuff that they're familiar with. I know I have certain scents, shampoos that I have that have a certain scent. Like right now I use almond butter and something else, Suave. I can't remember what the other scent is. But that scent, if they have a certain scent of shampoo, bring that scent in, and maybe that can help them to reorient themselves. Okay. Let's see. Also, keep in mind that you want to know what type of accident they had, because they may have other fractures or other injuries to other parts of their body, that's going to severely limit the types of interventions that you do and the plan of care. So it's always important to review that and talk to the family members. So that's your level 4. Any questions on that? Does anybody need like a few minute break before we go on to level 5? The last part of this chapter isn't as long as the first part of the chapter. So if y'all want to take about 10 minutes, go ahead. I'm going to keep the recording going, but come back at 5 minutes after 12. Okay?
If you want to eat healthy and feel your best, you gotta try Kachava. Kachava is the world's health.
All right, is everybody back? We're going to go ahead and finish up the lecture, and then I'm going to show parts of the video. So you got the Ranchos level 5. This level, a little bit easier to deal with than the level 4. They're still confused. They're still very inappropriate, but they're non-agitated. So they're not as angry as they were in the level 4. They have inappropriate responses to whatever stimuli they are given. Their memory and their attention continues to be very poor and very impaired. The client is not able to retain any new information. So the best types of treatments are going to focus on previously learned activities. Basic ADLs, things that they could do prior to their accident, dressing, feeding, their if they made their bed before, then maybe they could focus a little bit on that. Brushing their teeth, brushing their hair, anything that they typically did before is what's going to be a good intervention. Do not introduce anything new. They're not going to understand it. You're going to confuse them, and then you're going to get them angry. They have impaired safety awareness. So you're going to have to be there. They're going to have supervision with all of their treatments. They're normally still at an inpatient rehab, or they could be at a subacute rehab at this point. Maybe they've stepped down from the acute care. They usually have 24-hour supervision. Sometimes they can be transitioned to home and have 24-hour supervision with home care, home health, and outpatient OT services. You always want to start every single treatment by introducing yourself and giving an orientation of the time or of the date and the purpose of the session. Okay. So when you walk into every session, you talk to the person, you say, "Hi, I'm Jackie. I'm going to be your occupational therapy practitioner for today. It is March 23rd, 2022. And this is what the purpose of our treatment is today." Okay. That will help get them back to some orient them a little bit to today, to what's going on in the world today. You can address some cognition by using some functional stuff. Counting change is good. Just make sure that you supervise them while they're doing that. And you may either want to have them wear gloves or make them wash their hands immediately after. Watch that they don't handle this change and then put their hands in their mouth, because money is disgusting. Or you can use, some of the change that you already have in your rehab. I used to keep a bucket of, not really a great big bucket, but a small bucket of change, and clean it after someone used it with hand sanitizer and warm water. That way, if the next person came in and we were going to do some money stuff and counting change, then it was already clean. The money was clean. Still have them wash their hands, but it wasn't as nasty as the change that you get from everybody else. Sequencing is important. You can maybe have them make grocery lists. If they like coffee, having them make coffee. Maybe introducing some multi-step activities, like making a pot of coffee or making a cup of coffee. And then problem solving. If there's no cream, if they don't have the creamer for their coffee, how do you solve that problem? Maybe use milk if they've got it. So that's some things that you can do with the patients at a level 5. Now, you always want to incorporate clocks, calendars, other environmental cues to increase orientation. Memory activities are going to be important. One thing I used to do is have my patient's family bring a book or like pictures. Pictures are great, especially pictures like where they were in the pictures, or where, just familiar people, to kind of, help with their memory and help with some orientation. Let's see. Okay, so that's basically your level 5. You're going from agitated to non-agitated, but still confused. Okay. All right, then you get to the level 6, and at this point, it's starting to get a little bit easier. They're confused still, but they are appropriate. They have appropriate responses to the stimuli or to the treatment. They still have difficulties with recent memory, but they can use external cues for direction. Um, they they confabulate at this point. Um, they'll start to lie. Well, not really lie. They just believe that events from the past happened when they actually didn't. Um, and a lot of times they have this big gap in time. So and they don't remember what caused this accident. And whenever you've got a great big gap in time, you sort of want to fill that in with something because it's very unsettling to have a big gap in time. So if they don't know how the accident was caused or what's happened, they will start to make things up. I had one guy tell me that he was skiing downhill in Colorado and flipped over rocks and went down a 500-foot embankment, and that's how he ended up with his TBI. Well, that's not at all what happened. He was in a car accident. And the guy that was driving was drunk, and they all got into an accident and hit a tree, and he got his TBI. But no one had sat him down to explain this to him before. He had no idea what happened, so he just made it up. And come to find out that he did ski. He'd never skied in Colorado, never went down a 200-foot embankment, but that was his ultimate goal in life. He wanted to be able to ski in Colorado, down some big mountain that people aren't supposed to be skiing on, but that was his goal. And of course, he was a teenager, so of course that's what he wanted to do. But so you have to really kind of redirect them. And it is important to help them fill in those gaps of time with actual events. And don't say, well, that's a lie, because to them, it's not a lie. To them, it is something that they actually believed happened. So redirect and try to get them back to the task at hand. And then use your clinical judgment as to when you're going to bring up, well, do you remember anything about your accident? This is what actually happened. This is how this accident occurred. This is how you ended up with your brain injury. They may eventually forget about their confabulation and go to the real thing, but then again, they may not. But who are they really hurting if they don't? That's the way I always looked at it. If he wants to believe that he was skiing downhill and went over a 200-foot embankment and didn't die, then let him believe it. Who's he killing? Nobody. So at level 6, you want to help the patient keep a daily schedule, maybe keep a calendar. A phone, if a smartphone was part of their daily activity, which it probably was before their accident, then you may be able to fix most phones have S Pens, and they do require a lot of fine motor skill. If the patient doesn't have the fine motor skill to use that, then maybe you can develop some sort of device, or you could even use a universal cuff. Those things are wonderful, and help them fill in some of their calendars using an S Pen or even a paper calendar is fine. You could print one off the computer and let them use a paper calendar, and maybe in the beginning have them fill it out daily. This is what we're going to do tomorrow, and then this is what we're going to do tomorrow. And then, as they move along, maybe do it weekly and then do it monthly. You can use reminders for medications. They make these alarm medication boxes that have alarms on them. Those are really expensive. But I mean, if the family, the insurance won't pay for it. But if the family wants to buy them one, fine. But you could do the same thing with note cards. This is your medication. This is the day. This is the times that you take your medications, and have them fill out or put their medicines in this box. You don't do it for them. You direct them on how to do it, and you're there with them while they're doing it. So medication management is also important. maybe some long-handled things like long-handled sponge brush so that when they get in the shower, they can be a little bit more independent because they're still pretty off balance. So maybe they can reach down with their long handle and wash their lower body or their back or whatever. Carryover of adaptive techniques are going to be challenging for these people because of their memory deficits. The adaptive techniques were not something that was previously learned prior to the accident. So introducing this adaptive equipment is going to be very challenging for the person. You can also do a written exercise program, some type of handouts for the person. But also it's important to remember not all of your clients are going to enjoy exercising. So exercise is not, you can always ask the family member, did they like to exercise prior to their accident? And if the answer is no, then probably not going to enjoy exercising now. If they did, then, give them some exercises. Folding laundry is a really good activity. Using a rolling pin to roll out dough. That's a great bilateral activity, and it also incorporates some weight bearing activity. You may want to challenge two skills simultaneously at this point. So you can do like one great activity that I used to do with clients who like to play cards, standing at a table. I would have the table, one of those rolly tables, and they would stand up at it. But they would be like right in front of a mat table or right in front of their wheelchair or something like that. And I would be on the other side and we would play cards. So they're challenging their balance, but they're also playing cards, or we would play a memory game. Or have them standing up as they're doing as they're doing their calendar. So they're working on their balance, and they're also working on attention to task, and they're working on memory, things like that. Now, they also have a lot of difficulty with engaging in an activity. So they're probably going to require some initiation. They're going to require some prompting to initiate an activity. All right, so next is your level 7. Ranchos level 7, they're automatic and they have an appropriate response. Normally at this juncture, at this level, they're becoming more appropriate, and they're able to carry over some of their new learning. But it's at a slower rate, like like their adaptive equipment, things like that. They're beginning to be able to carry that over into their everyday function at a slower rate than before their TBI, but it's still there. Judgment continues to be impaired. At this point, you're going to start shifting to more IADLs. And you're going to also use a supervision rating scale, which if you look on page 900, table 34.3, that's your supervision rating scale. So let's say that they're at a level 3 for their supervision. But the patient is supervised overnight and part-time during waking hours, but is allowed on independent outings. So they're at the lowest level of supervision on the level 3, the part-time. So when they go on their outings, before they do that, you're going to want to go with them. So you're going to look at the supervision rating scale and look down a little bit and say, okay, no, well, they're actually at a 7. Okay. they need some assistance when they go out on their independent outings before they can decrease the level of supervision that they have. So you're going to want to work on money management. I know some of these community outings we used to do, we would go like get an ice cream. We would go to Dairy Queen, get an ice cream, and I would let them pay themselves. And they would have to order, they would have to pay, and that they would have to make sure that they got the correct change. They would also have to remain appropriate while in public, and kind of conform to society's rules when it comes to appropriate behavior in an outing. Um, they have to now at this time they're sometimes inappropriate with their speech. They will talk loud about inappropriate stuff, so they have to be reminded, they have to be redirected that that's not appropriate. There might be a bunch of kids around and they're sitting there cussing up a storm. You want to remind them that that's not appropriate, and that if they continue to do this, you're going to have to leave. You're going to throw the ice cream away and leave. And sometimes it does come to that. Sometimes it's okay, well then let's go, because they refuse to modify their behavior, and that's just part of it. You just gotta, behavior management is very important at this stage, because they're going to be going out, getting a job, doing things on their own, and society as a whole they don't understand. If you've got this person standing at a McDonald's by the play yard and they're cussing and carrying on, and um, they don't know any better. The person may not know any better because nobody's ever taught them, but society doesn't understand. So what do? They call the cops. What does the cops do? They try to arrest them. Chances are they try to arrest them and they fight. What does the cops do? They beat the hell out of them. So that's why it's important to do the behavior management while you're working with them. Groups are really important to work on social skills. Not only do they get cues from you and redirection from you as their practitioner, but they will also get some redirection from their peers. And it's kind of like they've crossed over. Think about kids, like teenagers. In the beginning, it's okay that mom and dad redirects them and they'll listen. But when they cross over to becoming a teenager, it's almost like they become pod people, and no longer what the parent says matters. It's all about their peers. If their peers think this is okay, then that's what they'll do. If they think it's not, then they won't do that. So it's sort of the same way with a level 7. If in social groups, if their peers say that's inappropriate, then they'll listen better than they will to you. Okay, so next we're going to go into the level 8. Ranchos Los Amigos, they are purposeful with an appropriate response. Usually they're in their own home environment. Sometimes they're in a group home, but most of the time their own home environment, provided that they can, provide financially for themselves. They demonstrate impaired abstract reasoning. So they can't really use a lot of logic and creativity when it comes to problem solving. Everything is just kind of what it is. So if you ask them where they live, they typically will say West Virginia in a house. Or they'll be very specific and they'll give you their home address. And you want to make sure that they're aware not to do that, because they also go on the internet. You don't want to give out your home address to just anybody. Now the plan of care for the level 8 is usually at a higher level, at a higher cognitive level, with cognitive skills. medication management, money management, community integration, things like that. That's normally what you're going to focus on. And a lot of times at this level, they're really not getting a lot of OT services. You may see them once a month in outpatient. You may, see them occasionally at their home. A lot of times you see them at a group TBI thing. And it's important to keep them involved if you have anything in the area that they can get involved with. It's important to keep them involved with that. Now, so why do you think that brain injury is a diagnosis that's said to affect the client and the family members, and not just the client?
Because of caretaker, the family has to really step in and help that client. Before that, they didn't really have to do much.
Right. Yeah, a traumatic brain injury affects everybody in the family. So the roles of the person who has the TBI, this might be the mom or the dad of a older kid or a teenager. So then sometimes the roles get reversed, and the teenager then becomes the parent. Or the older child sometimes becomes the parent, and that whole entire role is affected. So that's another thing to keep in mind when you're working with the caregivers. Sexual activity is very important, a lot, because typically the age range of an acquired TBI is 1 to 44 years of age. So when you start getting into those teenage years and up, then sexual activity is going to be affected. Let's say it's a married person. That's something that you're going to have to address with them. The sexual activity of the person with the TBI, and you're going to have to talk with them about different stress relieving positions and things like that. I watched a documentary one time where a guy woke up, and I really don't know how true this is. I guess it could happen, but he woke up after being like 10 years in a persistent vegetative state, and his daughter, who was like 6 or 7 at the time, when of his accident, was now a young adult. She was like 17 years old. And since, the mother, his wife had, moved on, she divorced him and did everything else. So when he woke up, he just thought that the daughter was his wife and started making sexual advances to the daughter. Well, is it really the dad's fault that happened? No. Does he need redirected? Absolutely. Do you talk to the daughter and the rest of the family about this? Yes. And try to make them understand that this is not something that is typical, that would be typical that he would do if he hadn't gotten the TBI and hadn't been asleep for 10 years. When in his brain, he still thinks that it's 10 years ago. He doesn't realize that 10 years has passed, and this is his adult daughter that was 6 at the time, or 7 at the time that he first got his TBI. Also, alcohol abuse. 2/3 of people who have a brain injury had prior history of alcohol abuse. So alcohol abuse is something that will continue to be a problem for these patients. Risky behavior is going to also continue to be a problem. A lot of people who are in jail right now have an undiagnosed traumatic brain injury. And I would venture to guess it's at least half of the people in jail in most jails have an undiagnosed brain injury, who are repeat offenders, I should say. Um, not just one and done, but who are repeat offenders, most likely have an undiagnosed traumatic brain injury. And I think that's why it's so important for OTs to work within the prison systems, so that we can kind of identify that and say, this person will still they'll still be a repeat offender unless someone steps in and helps them with their risky behaviors and, maybe provide some supervision. If you know anybody who was a higher up in the prison systems, tell me who they are and I'll walk to their office and say, put us in there. All right. So are there any questions on the TBI? I'm going to let you watch Understanding Brain Injuries yourself. That's really going to go over a lot of, but if you'll just watch the first 5, if you'll watch those first 5, those 5 videos that'll help. And then I am gonna play this. That's spinal cord. Hold on. All right, here's the Ranchos Los Amigos level song. Just a minute, let me. And if you can't hear this, holler out and let me know.
These are the Rancho Los Amigos. Levels of cognitive functioning. Level 1, no response like they're sleeping. Level 2, generalized response to pain. And with that level 3 is localized response inconsistently. And with that level 4 is confused, agitated, more alert than before. Level 5, confused, inappropriate. Gross attention to environment. Level 6, confused, appropriate. Response to commands is accurate. And look at level 7. Is automatic, appropriate, with robot-like performance. Level 8, purposeful, appropriate. Independent within home environment. Level 9, purposeful, appropriate. Standby assistance upon request. Level 10, purposeful, appropriate. Modified, independent.
All right, so there's other, if that one didn't spark your interest, which that one was the most boring to me. There's others that are a little bit faster that you may be able to remember. It is important to remember each level and the that level 1 is no response. So you need to know the level and the description of it. If you know the description of it, then you can probably pick out, some of the right answers to some of the questions, because this will be part of your MBCOT exam. The majority of my exam was on TBIs and spinal cord injuries. So what they'll ask is the person with the level 3 TBI, or the person with a TBI who's on a level 3 LCFS, the most appropriate activity would be money management, dressing, ADLs, sensory stimulation, or showering, independent showering. So you have to know what a level 3, a TBI level 3 LCFS, what that is, and be able to pick out the most appropriate activity. And it won't be that obvious. They may ask about a level 6. And so you need to know what a level 6 is in order to know what, so it's, those songs can help you remember each level. Because if you look at page, hold on a minute. Yeah, they used to have a chart. They may not have a chart. I'll see if I've got a chart. No, it's all in the paragraphs. Each paragraph, each level, it will give you examples of appropriate types of activities. If you're like me and you like to learn by charts after you read it and you want it in a chart because it's easier to understand, I'll see if I can find a chart that has that and pass that out to everybody. Okay. Is there any questions on today on the TBI? I know it was a lot of information. Do you see how a CBA and a TBI oftentimes is treated the same? Or similarly, not the same? Y'all still with me? Bueller? Anybody? So everybody here can see. Okay, y'all are still here. All right, so on Monday, I'm going to do a video. It'll be posting a video. And then Wednesday, we will do, you'll do some hands-on stuff with Professor Masilli. I don't know when your next practical is, but it won't be until after we do hands-on things. So let me look at the syllabus. Where's it at?
I have wrote down on April 11th.
Okay, April 11th is your next practical then? Yeah. This interprofessional health project, don't worry about that. We didn't do that this year. Treatment plan is due the 13th. So that means we have, what is this? Okay. So we only have 2 more chapters to do. Spinal cord injury and polytrauma. Okay. So what I may do is go ahead and try to do the lecture on both of these and post them for you to watch when it's convenient, and just try to focus from this point on a lot more hands-on stuff. That way you can be prepared for that and your final. Your final is going to be comprehensive. It's going to include a little bit of everything, but it will only be one specific diagnosis. And it'll be much like your first practical. I will send it out early. You will work on all of them, and you won't know what you're getting until you walk in. I just feel like it's, I would rather you learn about all of it than just one thing and just memorize everything in that one. So that's the reason I do it that way. And we will do times for your practicals, for your final practical, because each one will take a little bit longer because there's going to be a whole lot more involved in it. It's going to be comprehensive and include information from all of your courses. Okay. And we'll discuss that more later on. So Monday, just plan on watching the recorded lecture online, and then Wednesday, Professor Maselli will work with you on, unless I'm finished with all my meetings, but I doubt I will be. So Professor Maselli, you'll be here next Wednesday. Okay. What's gas prices where you all are?
$4.19.
Oh my God. Has anybody got cheaper than that? I think Beckley, some places in Beckley is $4.09.
It's $4.09 in White Sulphur.
Anybody else?
It's $4.09 in Princeton as well.
Well, all right. Until gas, I mean, would you all prefer? Now, this is going to be completely up to you guys. I'm here anyway, so it doesn't make a difference to me. And I just live 5 minutes from here, so gas is really not a problem with me. But I know a lot of you guys drive a far away. Do you all want to continue to do it the way that we're doing it, and one day a week be online? Or do you want to come back to class 2 days a week? If you want to continue to do it the way that we're doing it, just raise your hand. All right, so that's what we'll do. We'll continue to do it that way. That way, until gas goes under $4 a gallon and gets somewhat affordable again. That's what we'll continue to do. As soon as I find out anything about pinning, I have submitted information to the vice presidents, and I'm waiting on them to let me know. It's all up to them. It's supposed to be, and you can put this in your calendars just in case, it's supposed to be April 21st at 6 o'clock at the Charleston campus. I've requested to have families, to be able to have families there. Now, anytime that there's a gathering of 20 or more people on a UC campus, then there has to be, masks have to be worn. So if they do approve it, let your families know that they will have to wear a mask or they will be asked to leave. And as soon as I find out for sure that we're going to be able to do it then I will let you know. Okay? All right, so I will talk to you guys soon, and if y'all have any issues, you know where to find me. Bye.
Bye.